Hello, welcome to Simplified Med Ed. Today we are learning about hyponatremia. What is hyponatremia? Hyponatremia is when the serum sodium is low. So normal serum sodium is 135 to 145. If it is less than 135, then we call it as hyponatremia. And what are the symptoms of hyponatremia? The patient can have muscle cramps or weakness, lethargy, nausea and vomiting. He could have headache, confusion and seizures if it is really low. Now let's go and find here we'll discuss one case, and through that case we learn about the diagnosis and management of hyponatremia. So coming to the case, our patient is a 60-year-old male with past medical history of hypertension, diabetes. He presented with complaints of 6 days of weakness, but today he is unable to move and he was brought to ED by his family. And in the emergency department, he was found to have mild fever, which is 100.6, and coming to his labs, his CBC was normal, but his sodium is 116, which is like he's very hyponatremic and severely hyponatremia, and his potassium is 3.2. They did CT head, which is normal, and EKG showed sinus tachycardia. His drops were negative, and he was admitted to ICU for evaluation and management of hyponatremia. So he's also having kind of some infection, so he was maybe urinalysis was done, chest x-ray was done, or chest x-ray was done. So we are not going through all the other details, we are just focusing on hyponatremia for today. So management of hyponatremia, the most important part is the treatment. Why the management of hyponatremia? Before diagnosing, we have to first treat. So both of them goes hand in hand. So the first thing to consider for treatment is whether it's acute versus chronic, and second thing to consider whether it is symptomatic or asymptomatic. In our case, the patient was having symptoms from 6 days, and he is symptomatic. So he doesn't come under acute because the symptoms were going on from 6 days, so we don't know whether it is acute. So how do you define acute? Acute is defined as if the symptoms are less than 48 hours. So we don't know when his sodium went low, but assuming it's so severely low, like 116, it should be more than 48 hours, so it should be chronic and he's symptomatic. So first we'll check about the treatment of acute. So acute symptomatic, so first we do is 3% NaCl, this hypertonic saline, 100 ml is given IV bolus over 10 minutes, and then after 4 to 6 hours you can again repeat it until and then you only raise 4 to 6 milliequivalents slowly in 24 hours. And you should remember that correction should not be faster, and it can be faster in acute, but it cannot exceed more than 10 to 12 milliequivalents within 24 hours. And second thing, or it should not exceed more than 18 milliequivalents in 48 hours. So next, going to the chronic, where it could be more than or equal to 48 hours. That's when it's termed as chronic hyponatremia. And again here, if he's symptomatic, we give hypertonic saline, but we aim for only 4 to 6 milliequivalents per liter increase in first 6 hours to control symptoms, and then slow down. And if it is asymptomatic, we have to treat the underlying cause. Only if it is symptomatic, you give hypertonic saline. If it is asymptomatic, you treat the underlying cause. And to check the underlying cause, we have to check serum osmolality and volume status. So here the correction should be less than or equal to 8 milliequivalents for 24 hours. So whereas here in acute, it could be more than 10 to 12 milliequivalents, should not exceed 10 to 12 milliequivalents, but in chronic it should be less than or equal to 8. So if you remember, it should be 10, it could be 10, here it should be less than or equal to 8. Now coming to the asymptomatic hyponatremia. Before that, we have to remember what happens. Why are we saying that it should not exceed? So when you correct hyponatremia very quickly, that is more than 8 milliequivalents or more than in 24 hours or more than 18 milliequivalents in 48 hours. So that's when the pontine myelinolysis happens. So low, there is a mnemonic for that. There is a it's not a mnemonic. There is a phrase for that to remember. Low to high pointines will lie. High to low, if it is hyponatremia, when you correct it quickly, then the brain will blow. So it will cause cerebral edema. Now, hyponatremia, coming to the hyponatremia table. So for hyponatremia, to diagnose it, first we have to check the serum osmolality. The normal serum osmolality is 275 to 295 milliosmoles. So if it is depending on serum osmolality, it is divided into three types. That is hypertonic hyponatremia when serum osmolality is less than 275, isotonic when serum osmolality is normal, and hypertonic when serum osmolality is more than 295. So the hypotonic hyponatremia is a little bit complex. We'll discuss it later. First, coming to isotonic hyponatremia, where the serum osmolality is normal. This could be a lab error. It's actually not hyponatremia. It's a pseudo hyponatremia. It should be due to if the patient is having either hypertriglyceridemia or dyslipidemia or increased proteins. That's when you get sodium levels low, but it's actually the sodium levels are normal. To check that, if you order whole electrolytes, you get normal sodium levels. And in hypertonic hyponatremia, this could be due to hyperglycemia or increased solutes like mannitol or sucrose. So, and here you can correct the underlying cause, like if it is hyperglycemia, which could be due to DK or HHS. If you correct that, then the hyponatremia will correct itself by itself. So for that, you do IVF and insulin. So that's how you deal with these both isotonic and hypertonic. Now let's go to the next slide, which shows hypertonic hyponatremia. So here, the first thing we have to consider is the volume status. How do you check the volume status? By checking the patient's skin turgor, if he's having any hypertension, if he's having any edema, if he's having dry mucous membrane, tachycardia. So all these things will tell you about the volume status of the patient. So depending on that, you divide again the patient into either hypovolemic or euvolemic and hypervolemic. Here, after checking the volume status, you need to check urine sodium and urine osmolality. So you order this right in the ED when the patient was admitted, so that you get the results, all the results, and you can immediately treat. So depending on the volume status, actually you can determine the treatment. So if it is hypovolemic, so you give IV fluids. So if it is euvolemic, you do fluid restriction. If it is hypervolemic, you give diuretics. Now let's see about hypovolemic. Learn about hypovolemic. In hypovolemic, you check urine sodium. If the urine sodium is less than 20, that means it could be so if urine sodium is less than 20, that means kidneys are functioning properly. They are concentrating urine properly. So that means it could be either due to GI loss, like nausea, like vomiting, diarrhea, or it could be due to third space loss like bleeding, trauma, burns, pancreatitis. Next, if the sodium is more than 20, that means kidneys are not concentrating properly, most probably due to diuretics. So you stop the diuretics and give IV fluids. Now, next thing is euvolemic hyponatremia, euvolemic hypotonic hyponatremia. That means here the volume status is normal, his skin turgor is normal, he's not having any hypertension, no mucous membrane, moist mucous membranes, everything is normal, no edema. So here if you check urine osmolality, if urine osmolality is more than 100, that means his ADH is not working properly. It's probably due to SIADH, or it could be due to any thyroid, hypothyroid, or due to cortisol. So you check along with the you check also TSH and serum cortisol. And then if you if urine osmolality is less than 100, then his ADH is working properly, it's suppressed properly. Then it could be due to increased water intake like beer potomania or primary polydipsia. Here you just do fluid restriction. Okay, and then if it is SIADH, then You check for any underlying causes, if he's having any cancer that's causing. So that's totally another topic. Now coming to hypervolemic, where you can see pedal edema, volume overload conditions. He is having tachycardia, sorry, not tachycardia, he's having swelling on the sarca, or all those things. That's when you give diuretics. But what's the cause? Here you check the urine sodium again, as in hypovolemia. If the urine sodium is less than 20, that means it could be due to that kidneys are working properly. It could be due to CHF or cirrhosis or nephrotic. If urine sodium is more than 20, then it could be due to kidney failure like AKI or chronic kidney disease. So that's about the treatment, and that's about the table. And next, the admission orders. So when you get the patient with hyponatremia, what are the orders that you have to put in? So first, you check whether the patient is symptomatic or asymptomatic. If the sodium is less than 120, or if it is, then you admit to ICU, or you depending upon the patient's status, his stable, if he's stable or not, if he's very symptomatic or if he's asymptomatic, you decide whether to admit ICU or admit to floor. And then you do the vitals every 6 hourly or 24 hours depending on the patient's status. And here in hyponatremia, you have to check repeat sodium every 2 hours. And if you're if he's symptomatic and if you're treating aggressively with 3% or hypertonic saline, that's when you check sodium every 2 hours so that it is not overcorrected. And also you put protocols like hypoxia protocol, seizures if he has nursing call for seizures or obtundation, and you check volume status. Depending on that, you either do fluid restriction or IVF, and you do BMP, you do serum osmolality, urine osmolality, urine sodium, and then you do TSH, serum cortisol, and HIV. Why HIV? Sometimes many times HIV patients do have hyponatremia. Now coming to the topic overcorrection. This is a very important topic because this is the problem that can happen, and it's one thing that we deal with in ICU when we are correcting hyponatremia. So the thing is, we should remember that sodium should not be corrected more than 8 to 10 milliequivalents in 24 hours, or more than 18 in 48 hours. That if it is done more than 10 in 24 hours or more than 18 in 48 hours, that's when the overcorrection happens, and it can lead to pontine myelolysis. So the first step is you stop the ongoing correction. If you're giving hypertonic saline, stop it. If you're giving any other interventions in raising sodium, you just stop those things. As the second thing is you re-lower serum sodium. To re-lower serum sodium, what you have to do is you either give IV desmopressin or you do free water replacement with 5% dextrose water IV. Okay, you do those things. Then you also monitor serum sodium every 2 to 4 hours, and you adjust fluids and desmopressin according to the sodium levels. And also you treat and identify and treat underlying causes. It could be due to diuretics. You stop if there are any offending agents, and you also manage hypovolemia if there's any adrenal insufficiency. And your target correction should be less than or equal to 8 in 24 hours and less than or equal to 18 in 48 hours. And you also consult a specialist, that is nephrologist, if there is rapid overcorrection or if there is high risk of other comorbid conditions, like if he's alcoholic or malnourished, or if he's having liver disease or hypokalemia. Now let's check new trials for any problem or any thing. We need to always, as an intern, need to always check the new trials and that are going on the topic. So let's check few new trials. So the first trial that we are discussing here is proactive versus reactive desmopressin for severe hyponatremia. So for severe hyponatremia, you only give desmopressin when you overcorrect, right? But here they're suggesting if you give desmopressin along with 3% that is hypertonic saline, then there are less chances the patient less incidence of overcorrection. So this study says that. And next there is one more study. The next study is tolvaptan versus fluid restriction for moderate profound SIADH. So SIADH comes under euvolemic hypotonic hyponatremia. So here we do fluid restriction and if there are any underlying causes, but here in this study they use tolvaptan. And what is the outcome? Says that from this study will help clarify the role of tolvaptan as a frontline treatment for hyponatremia from SIADH, especially compared to the traditional approach. That's interesting. The next study is oral urea for chronic hyponatremia. Many old patients, they will be having chronic hyponatremia which is asymptomatic. So for such kind of patients, there is a thing that they in Europe they use oral urea. This urea works by inducing osmotic diuresis, removing excess free water and safely raising serum sodium levels. So this study is pilot study is underway to evaluate the feasibility and acceptability of oral urea for ambulatory patients with chronic non-severe hyponatremia, not severe hyponatremia, chronic and also non-severe. And we'll see if urea becomes a part of chronic hyponatremia treatment in later on. Next study is targeted automated e-consults called TACOs for inpatient hyponatremia. So here they propose this study trial where whenever the patient is inpatients, whenever they get hyponatremia, there is this automatic e-consult that goes to a specialist team, and when the inpatient was identified and they act immediately, so that it wouldn't be missed and you don't have the complications of it. And the last one is here is protocol driven improvements to prevent overcorrection. So protocol driven improvements here, this is an interesting study in Westchester Medical Center where the nephrologist team and the ED team came together, and they started like if the serum sodium is 125, they are not usually, whenever you see hyponatremia they start giving IV fluids, but the nephrologist have said that whenever the sodium level is 125, please don't give IV fluids but start doing urine sodium, urine osmolality, serum osmolality, and you use IV fluids cautiously and immediately consult nephrology. So that way the aim is to decrease the incidence of overcorrection before. So they found that this protocol really worked in decreasing the cases of overcorrection. So we need such studies, and as an interns or as medical students, if we have interest and if you keep reading such studies, you will know how to do more studies yourself or more papers yourself, and you would also learn a lot about the topic. And I think we are done with this. Before going, I just wanted to quickly summarize the things that are important here. So what are the important things are in the management of hyponatremia? First, quickly summarizing in 2 minutes, if it is acute or chronic, or if it is symptomatic or asymptomatic. If it is symptomatic, acute, like you give 3% NaCl bolus and again you repeat it 2 times or 3 times, and you always make sure that it is not corrected more than 10 to 12 milliequivalents in 24 hours. And if it is chronic, it should not be corrected more than, it should be less than 8 milliequivalents. And then the next one is hyponatremia table. You first check the osmolality. Depending on osmolality, if it is euvolemic, then that means it is if it is isotonic, that means you don't have to do anything, it is a pseudo hyponatremia. And then if it is hypertonic, you check the solutes like hyperglycemia, any other problems, you correct those. And if it is hypertonic, then you check the volume status. Depending on the volume status, you correct, like if it is hypovolemic, you give IV fluids. If it is on diuretic, you stop diuretics. If it is euvolemic, you do fluid restriction. If it is hypervolemic, you give diuretics. Again, for hypovolemic, you check the sodium more than 20, then diuretics is the cause, you stop diuretics. Less than 20, it could be GI loss, you give IV fluids. And if it is euvolemic, you check urine osmolality. If it is less than 100, that means it's taking excessive water, you do fluid restriction. If it is more than 100, SIADH, or it could be thyroid or adrenal, you check the underlying cause by checking those. And if it is hypervolemic, if the urine sodium is more than 20, then it could be due to kidney failure like AKR CKD, or if it is less than 20, it's due to CHF, cirrhosis, or nephrotic, you check the cause. So, and then you check the admission orders. We have discussed everything. So those are the important factors that you have to remember, and once you remember those, you'll know how to manage hyponatremia, and it becomes easier. Okay, thank you all for staying with me through this presentation. Hope you learned something today, and let's meet you all in the next video of Simplified Med Ed. And please support my channel if you like it. Bye bye.